بسم الله الرحمن الرحيم. We'll talk today about genital herpes. Those are the topics which we will discuss: the virology, frequency, clinical varieties, transmission, complications, lab diagnosis, and management. The herpes viruses, family Herpes viridae, are a group of double-stranded DNA viruses that replicate inside the nuclei of their host cells. This is an electron microscopic picture of the herpes virus. This is the glycoprotein, which is antigen determinant. This is viral envelope. This is tegument. This is DNA genome inside, and the capsid. We can classify herpes viruses into alpha herpes viruses, beta herpes viruses, and gamma herpes viruses. The alpha herpes virus include the herpes simplex virus type 1 and 2 and varicella zoster virus. Beta herpes viruses include the cytomegalovirus, human herpes virus type 6, and the human herpes virus type 7. The gamma herpes virus include Epstein-Barr virus, human herpes virus type 8, or Kaposi sarcoma associated herpes virus. The herpes simplex virus are classified into two types, type 1 and type 2. They share some antigenic components, so antibodies that react to one type may neutralize the other. There are certain biological properties of the herpes simplex viruses. The first of all is the neurovirulence, or the capacity to invade and replicate in the nervous system. Also the latency, or the establishment and maintenance of latent infection in the nerve cell ganglion. Herpes simplex virus type 1 usually affects the trigeminal ganglia, while the herpes simplex virus type 2 usually affect the sacral nerve root ganglion from S2 to S5. The reactivation and replication of latent herpes simplex virus can be induced by a variety of stimuli, like stress, menstrual cycle, also pregnancy or sexual intercourse, or even sun exposure can cause induction of the shedding of the peripheral herpes virus. Herpes virus type 2 reactivates 8 to 10 times more frequently than compared to orolabial herpes simplex virus type 2. It is something strange, despite it is the same virus, but replicate more at the genital area than the orolabial area. Reactivation is more frequent and severe in immunocompromised patients. In the United States, approximately 45 million individuals aged 12 years or older, 1 in 5, have been infected with genital herpes. Each year, 1.5 million new cases are diagnosed. Currently, approximately 50% of genital herpes simplex infection are caused by herpes simplex virus type 1, while 85 of cases caused by herpes simplex virus type 2. Now we will classify clinically the genital herpes into primary, non-primary first episode, recurrent, and asymptomatic viral shedding. In the primary infection, this patient didn't expose to herpes simplex virus before, so there is no type-specific immunoglobulin G antibodies to either herpes simplex virus type 1 or type 2 at the time of appearance of the lesion. Lesions appear 2 to 40 days after exposure. Lesions usually last 20 days. Viral shedding usually lasts 12 days. Take care of these numbers. Lesions usually last 20 days and viral shedding lasts 12 days. Antibody response occurs 3 to 4 weeks after the infection and is lifelong. So, at the beginning of the infection, in the first 3 to 4 weeks, if we do serological test, it will be negative. It will be negative. So, negative serological test didn't mean that this patient is not infected. Local symptoms include intense pain, dysuria, itching, vaginal discharge, and lymphadenopathy. There are other constitutional symptoms like fever, headache, nausea, malaise, and myalgia. This is due to viremia. The signs are tender vesicles which may rupture and become ulcers. In female, the vaginal mucosa is commonly inflamed and edematous. The cervix is involved in 70 to 90% of the patients and is characterized by ulcerative or necrotic cervical mucosa. In males, it affects the glans penis, prepuce, the shaft of the penis, and sometimes on the scrotum, thighs, buttocks, urethritis with mucoid discharge, and dysuria may be very severe and cause urinary retention. And something strange, that herpes simplex virus type 1 causes urethritis more often than that of herpes simplex virus type 2. As you see here, there is ulceration after vesicle. Here also, at the shaft of the penis. This is ulceration after rupture of the vesicle at the labia and at the fourchette. More than 75% of women with primary genital herpes simplex virus infection are asymptomatic. Asymptomatic primary herpes simplex virus infection in gravidas at term are responsible for most neonatal herpes simplex virus infection. Non-primary first episode. In these patients, the patient has already exposed to one type of herpes simplex virus, but he catch the other type at the time of examination. So, first genital herpes simplex virus outbreak in patients who has heterological herpes simplex virus antibody. For example, a patient developed herpes simplex virus type 2 lesions on the labia for the first time, but he or she have antibodies against herpes simplex virus type 1 prior at the time of genital outbreak. Because of partial protection of the pre-existing antibodies, these patients tend to have fewer and shorter systemic symptoms. The duration of the lesion is shorter, average 15 days, and shedding lasts for approximately 7 days. You know that in the primary case, it was 20 and yes. Diagnosis is based on type-specific culture and the type-specific serology. The absence of any herpes simplex virus antibodies at the time of outbreak confirms a primary infection. But the presence of antibodies to another type of the herpes simplex virus confirm a non-primary first episode infection. The recurrent infections, a genital herpes simplex virus outbreak in a patient with homologous immunoglobulin G antibodies to herpes simplex virus type. Recurrent infections occur most frequently during the first 3 months after a primary infection, especially with herpes simplex virus type 2. Approximately 50% of all pregnant women with a history of genital herpes simplex virus infection experience recurrent lesions at delivery. Both subclinical and symptomatic reactivation are more common with herpes simplex virus type 2 compared to herpes simplex virus type 1. The symptoms are more severe in women than in men. Recurrent genital herpes is preceded by a prodroma of tenderness, pain, and burning at the site of eruption that may last from 2 hours to 2 days. Then mild vesicle appear. Lesions typically last for 9 days, and shedding lasts for approximately 4 days. Asymptomatic viral shedding. Asymptomatic viral shedding is episodic and brief, usually lasting 1 to 2 days. 1 to 2% of the pregnant women with a history of recurrent herpes simplex virus infection have asymptomatic shedding at the time of delivery. How can the herpes simplex virus can be transmitted? The mode of transmission is by close personal contact. Infection occurs via inoculation of virus into susceptible mucosal surface or through small cracks in the skin. Herpes simplex virus can be vertically transmitted from the mother to the infant, before, during, or after delivery, although intrapartum transmission occurs for most cases. Now, what are the complications of herpes simplex virus? The first of all, bacterial and fungal superinfection, balanitis and candidal vaginitis, ocular infection, skin infection, eczema herpeticum, and herpetic whitlow, disseminated visceral infection, mainly the hepatitis, CNS complication, aseptic meningitis, ganglionitis, myelitis, and encephalitis. Neonatal herpes simplex virus disease. As we said before, there is antenatal and at the time of labor and postnatal. Antenatal, 5% of all cases of neonatal herpes simplex infection results from in utero transmission by hematogenous spread to the placenta and to the fetus. This may lead to microcephaly, microphthalmia, intracranial calcification, and chorioretinitis. Intrapartum, which account for the most infected infants and occurs from passage of the infant through the infected birth canal. 75 to 90% of infants with neonatal herpes simplex virus are born to infected asymptomatic mothers who have no known history of genital herpes. The disease may be confined to the skin, eyes, mouth, or it may manifest as encephalitis or disseminated visceral disease involving lung, liver, heart, adrenals, and skin. Postnatal can occur through contact with infected parents or healthcare workers. There is a relationship between the genital herpes simplex virus and HIV transmission. Prior herpes simplex virus type 2 infection has been shown to increase the chance of acquiring HIV infection by 2 to 3 folds. This may be due to the inflammatory cells and the mediators which accompany the herpes simplex virus infection may increase the chance of HIV transmission. Also, the manifestation of genital herpes is more severe in HIV patients. Now we'll talk about the laboratory diagnosis. First of them is the serological test. IgEG, or type-specific HSV. This assay can distinguish differences in the surface glycoprotein G between the two herpes simplex virus subtypes, thereby enabling to distinguish herpes simplex type 1 and herpes simplex type 2 antibodies. This IgG is, as you know, lifelong. IgM antibodies detect recent infection. Some believe that it is unuseful, it's not useful. Antibodies or antibody titer increase generally didn't occur during recurrence of herpes simplex virus. So it is only not useful. Limitations of serological tests. It cannot identify the site of infection or prove that genital lesions are due to herpes simplex virus infection. Negative serology may not mean that the patient is not infected. The patient is seronegative 3 to 4 weeks, as we said before, after primary infection. There is risk of inaccurate result, false positive or negative. Other tests such as herpes simplex virus culture or T-zinc smear may be used. Also PCR, which can distinguish between type 1 and type 2. We'll talk now about the management. The first drug is the Acyclovir. It is synthetic purine nucleoside analog. It is highly selective for virus-infected cells. It is phosphorylated twice. First of all by viral thymidine kinase, then by cellular kinase, which transformed into the active form or nucleoside triphosphate. Valacyclovir, it is a prodrug. It is transformed into the body into acyclovir. It is more expensive but has more convenient dosing regime than acyclovir. Famciclovir, also it is a prodrug, transformed in the body into bencyclovir. It inhibits the viral DNA synthesis and replication. This comparison between famciclovir, valacyclovir, and acyclovir about the bioavailability and many other things. We can copy this for you if you'd like. We'll talk now about the doses of the antiviral drugs. I'd like to say something as regard the two new drugs, valacyclovir and famciclovir. They are always has equal benefit, almost. But sometimes we see that some patients benefit more with famciclovir and another benefits more with valacyclovir. We didn't know exactly the cause of this, but clinically we see that. As regards the dose, valacyclovir in the first episode, 50 milligram twice daily for 10 days. Acyclovir, 200 milligram 5 times per day for 10 days. Famciclovir, 250 milligram 3 times daily for 10 days. Recurrent episodic treatment, valacyclovir 500 twice daily for 5 days. Acyclovir 200 milligram also 5 times daily for 5 days, and famciclovir 125 twice daily for 5 days. In HIV infected, we don't use valacyclovir or acyclovir, but we can use famciclovir by the dose of 500 milligram twice daily for 7 days. Suppressive treatment, we use 500 milligram once daily for 6 months, 200 milligram 3 to 5 times daily for 1 year, and the famciclovir 250 milligram twice daily for 4 months. Vaccines, till now, no effective vaccine is discovered, but many trials since 1950. Those are some trials. Living attenuated vaccine consists of live herpes virus that missing critical genes for replication. On animal studies, they decrease the recurrence of genital herpes. Viral antigens vaccine consists of viral antigens that presented to the immune system and activate both helper and killer T cell response. It had no effect on the men, but can cause some effect on the women which did not expose to herpes simplex virus before. Also, there is viral DNA vaccine, which is something new, but till now not approved. Prevention of vertical herpes simplex virus transmission. This recommendation is since 1999. Women with primary herpes simplex virus infection during pregnancy should be treated with antiviral therapy. Usually we use Acyclovir. We don't use fam or valacyclovir because there are no enough researches for this. Cesarean delivery should be performed on women with first episode herpes simplex virus infection or with recurrent herpes simplex infection who have active genital lesions or prodromal symptoms at delivery. But those who didn't have active lesion or prodromal symptoms during labor, cesarean delivery should not be performed. For women at or beyond 36 weeks of gestation with first episode of herpes simplex virus infection occurring during the current pregnancy or at risk for recurrent herpes simplex virus infection, antiviral therapy should be considered.